Evolution of Management of Congenital Pulmonary Airway Malformations, Single Center Experience by Anu Paul.
Good morning. I'm way too old to be a postgraduate student. I would like to present our King's College Hospital experience of the evolution of the management of congenital pulmonary airway malformations over a period of 18 years. So, improved antenatal ultrasound has resulted in increased detection of antenatal congenital anomalies. And then with that comes the controversy of what exactly to do with these lesions. So in the UK, opinion is divided on whether to manage these with operation or to manage them conservatively. At King's College Hospital, we offer surgical resection for all lesions that are symptomatic, for those where the diagnosis is doubtful, and for those where the appearance and the site of the lesion is thought to be a likely presage for complications. This study is a retrospective case note review of patients who underwent surgical treatment for congenital pulmonary airway malformations between the years 1995 and 2013. In our practice, all those who had antenatally detected lesions underwent a CT scan of their chest, preferably at 6 weeks of age, and those who presented postnatally would have had a CT scan to detect these and confirm them anyway. So we had 133 antenatally detected lesions. 4 of our patients presented later in life with respiratory symptoms and were diagnosed then. So we had a total of 137 lesions. 18 of our patients underwent fetal intervention, and the majority of these were thoracoamniotic shunts. A few of them had laser ablations of vessels supplying the lesions, and then the other procedures as listed. And here we have a picture of one of the babies who was born with the shunt in situ. And in those babies who had had antenatal interventions, our practice was to offer operation early in life and at a median of 4 days of life. In our institution, we started to offer thoracoscopic resection from 2008 onwards. So ours is a fairly brief experience. And this chart shows the evolution of trend in the type of operation that we offered. So as you can see, over the last 5 years, thoracoscopy has become pretty much the default operation that we offer. But also, if you look at the trend of those bars, you can see that there is an increase in the number of cases that we're doing as the years go by. And this again goes back to the comment that we're detecting more of these antenatally. So comparing our thoracotomies and thoracoscopies, we've only got a small series of 35. And as you can see, we offer thoracotomies in the younger age, and our thoracoscopies were performed around 10 months of age. But doing it thoracoscopically added a huge amount of time to our operating time, although there was a slightly reduced post-operative stay. There were some early neonatal deaths, which could be attributed to the size and the severity of the lesions themselves. Among the post-operative complications, the most common was a prolonged air leak. One of our patients had scoliosis on long-term follow-up, and that was a patient who'd had an open resection. The last patient who had hemiparesis was actually a catastrophe because of a poorly managed post-operative electrolyte imbalance. The histology breakup shows that the majority of these lesions were CPAMs, or congenital cystic adenomatoid malformations, and closely followed by sequestrations. So to conclude, ours is perhaps the largest surgical series from the UK. Surgical excision, whichever method you choose, is clearly safe and minimizes the risk of future complications. And perhaps 5 more years down the line, when we have enough thoracoscopic cases, we will be able to present to you a more meaningful comparison of the outcomes of doing these open and thoracoscopically. And so looking to the future, I'd like to leave you with this video of our patient who, this is the morning after she's had her thoracoscopic resection of a sequestration. And you can see she's dancing around with her chest drain still in situ. Thank you.
It is excellent paper. I ask for any comments from the floor.
Thank you, Anu, for a very nice paper. I would like to know, if you have talked only about the surgical patients. I mean the patients who has had surgery. So at the current scenario, how it is, what percent of these patients will be treated conservatively and what percent will be treated surgically?
So if they come to King's, I think almost all of them will be offered surgery. It's funny that in the UK, north and south of the Thames River, they're getting different options of management. At least at King's, what we try to tell the patients is that in the UK, opinion is divided, and these are the pros and cons of conservative management and operative management. But at King's, we firmly believe that we can't offer 100% accurate follow-up unless you keep doing CT scans. And exposing a child for CT scans just for the sake of following up this lesion, we feel is probably more morbid than doing an operation and taking it out. This was
because in Australia, they are doing totally conservative management.
Yes. So in London, we're doing operation. In Southampton, they manage them all conservatively. So.
I went through your chart, all your lesions. How many were hybrid lesions?
How many were hybrid lesions?
Hybrid lesions.
I have the percentage. Can I go back on the slide? So I've separately put I can give you the exact number afterwards, sir. I've separately put the ones that were considered pure CPAMs and the ones that were considered hybrids.
Thank you, Dr. Anu. We'll close further discussion. Yeah.
Just a quick comment. Soundapan from CHD. Quick question. How much do you think thoracoscopy has contributed to the increased surgical practice of these lesions?
That's a very fair question, fair point. Are we operating on them because we like to do the operations? So I hope we are operating on them because we feel that that's a safe option to offer rather than this, but it's a fair point to raise, and I'm sure it does influence us in some way.
Thank you.
Thank you.